Hello everyone. So today our topic of discussion is hypertension in pregnancy. This is a very important topic and we accept one question from this topic. Okay, so let's start it. So this is a question from FMG June 21. 26 weeks pregnant female presented with hypertension for the first time and there is no proteinuria. What is the diagnosis? Okay, so if there is no proteinuria, then it is a gestational hypertension. It is not chronic because it is after 20 weeks. So answer is gestational hypertension. Okay, now these are some of the definitions. Gestational hypertension means if the BP rises more than 140 by 90 for the first time in pregnancy after 20 weeks. Okay, why it rises after 20 weeks we will just see after a few minutes, and that rise in the BP get normalizes after 12 weeks of delivery. Okay, and here we have to take two BP recordings 6 hours apart. Okay, what happens in the preeclampsia? What is preeclampsia or preeclampsia toxemia? In this, in addition to the gestational hypertension, there is proteinuria. What is proteinuria? That the protein comes in the urine. Normally some amount of protein do come in the urine, but if it is more than 300 mg in the 24 hours, or it is more than 1, or it is 1 plus in the dipstick, or more than 30 mg per deciliter, then we called it a proteinuria and we call that patient as preeclampsia. Okay, we also call it these days preeclampsia toxemia. Okay, so the new term is preeclampsia toxemia. Okay, now what is chronic hypertension? It can also be there that the lady is suffering from the hypertension before the pregnancy. So, and in that case the BP will rise before 20 weeks. Okay, so if the BP rise before 20 weeks and it persists after 12 weeks postpartum, then it is a chronic hypertension. Okay, so there is one more term, acute on chronic hypertension. What is acute on chronic hypertension? If chronic hypertension was existing, now body is getting some acute symptoms. So the what are those acute symptoms? You all know that increased blood pressure affects mostly the liver and the kidney, so they can be deranged liver function test or renal function test, or there can be new onset proteinuria. So if that chronic hypertension it get aggravates in pregnancy, then we can say it acute on chronic hypertension. So or you eclampsia, you all know, I need not to tell you. Now let's see this another question. It has come in NEET PG. Which of the following features are helpful in differentiating chronic hypertension from PIH? So answer to this question is hypertension at 10 weeks of gestation, because PIH or pregnancy induced hypertension is always after 20 weeks. Now let's study what happens after 20 weeks. 34 years woman develop preeclampsia at 28 weeks. She is very anxious and asks why this happens. You explain, sir, that there is a problem in development of fetocircular maternal circulation. What is the problem? Okay, so here I would like to tell you, you all know that, see here, there are villi. Villi is, what are villi? Villi are the umbilical vessels, branches in the placenta. Okay, so these are villi. Okay, now in between the villi here are the spiral arterioles. Okay, now spiral artery is the last branch of the uterine artery which supplies the decidua. Okay, so this is spiral artery, arterioles you can see. Now these villi are lined by trophoblast cells. Okay, so these cells are trophoblast cells. Okay, okay, now what does the cells which line this trophoblast are known as villus trophoblast and some extra cells which are known as extravillous trophoblast. ठीक है, what this do, this is happening in a normal pregnancy. Okay, what does they do, this extravillous trophoblast? Now you all know that every arteriole is made of three: tunica interna, media and externa. Okay, now this extravillous trophoblast, they invade the spiral arterioles. This extravillous trophoblast, they invade the spiral arterioles and they replace the tunica media. Okay, and it replace the tunica media. And if this invasion is poor, ठीक है, all here also, and if this invasion is poor, it means that extravillous trophoblast is not able to replace this tunica media, then preeclampsia happens. What will happen if they are not able to remove the tunica media? Then the spiral arterioles will remain spiral arterioles. If they are not able to remove the tunica media, then they will remain contracted. So the exchange will not be there, so there will be vasospasm. Okay, so you can appreciate in this diagram, these are the villi and these are the spiral arterioles. So here extravillous trophoblasts are coming and invading the spiral arterioles and removing the tunica media, okay, of the spiral artery. So now this artery which was like this, now it is in the dilated form. So now the exchange between the spiral arteries blood and the villi blood can occur effectively, but this does not happen in preeclampsia. In preeclampsia there is poor invasion. Let's see this question now. 34-year woman develops preeclampsia at 20 weeks. Okay, what is the poor invasion by villus? No, villus trophoblasts, they always form the villi. Okay, so they always form the villi. Okay, so it is the poor invasion by extravillus trophoblast. Okay, of spiral arteriole. So answer is this C, because spiral arterioles supply the uh, decidua or the endometrium. Okay, okay, I hope you got it. So this is the main reason, etiology of preeclampsia. Okay, INICT May 22 question, incorrect regarding the pathogenesis of preeclampsia. Now due to this poor invasion, everywhere there is vasospasm. Just see here, ठीक है, everywhere there is vasospasm. ठीक है, everywhere there is. So if you say one word is vasospasm in the mother, all arteries there is vasospasm. Now and some angiogenic growth factors they decrease and some angiogenic growth factors they increase. Which angiogenic growth factors decrease? Okay, so these have been asked. ठीक है, some angiogenic growth factors they all the soluble they decrease. ठीक है, what does this SFLT stand for? Soluble FMS like tyrosine kinase. ठीक है, just to learn you have to learn that all the soluble or soluble endothelin, all the soluble they decrease. Sorry, they increase. All the soluble ones they increase, and all the VEGF, all the growth factors, PIGF, ठीक है, they decrease. All the soluble angiogenic growth factors they increase, and all uh, uh, the VEGF and PIGF they decrease. Why they decrease? Because they soluble growth fact, the soluble FLT1 and soluble endothelin, these they bind in the VEGF and PIGF. So these is they bind the growth factors. So as a result, the growth factors they decrease. Okay. Now the another pathology is that the vasoconstriction. Now first pathology you have understood that these growth factors they decrease. Okay. Now another pathology is that there is vasoconstriction. So all the vasoconstrictors they increase. So thromboxane A2 it increase. Okay, thromboxane A2 and or the vasodilator they decrease. All the vasoconstrictor increase and all the vasodilator they increase. Okay. Okay, do you got it? Okay. Okay. Now one thing is that all the soluble factors they increase and they cause the decrease in the. Yes. So number one pathology is all the soluble factors they increase and they cause decrease in all the growth factors. Number two pathology is all the vasoconstrictor increase. So thromboxane A2 also increase and all the vasodilators they decrease. Number third pathology is that there is endothelial dysfunction. So there is leakage. ठीक है. So there is leakage or you can say edema, and due to this leakage there is hemo concentration which leads to end organ damage. So now let me read you all these things which have come in the question. Okay, see, angiogenic growth factors play role in preeclamptic women, and there is increase in soluble FLT1 and decrease in PIGF. So this is right. Vasoconstriction leads to ischemia, necrosis, hemorrhage, and end organ damage seen in preeclampsia. Yes. Prostaglandin 2 play role, and there is decrease in thromboxane A2 and increase in prostaglandin I2. Oh, yes. Endothelial cell dysfunction lead to less nitric oxide, and so this is wrong. So there is not decrease in the TXO2, there is increase in the TXA2. Endothelial cell dysfunction leads to less nitric oxide level and cause the clinical presentation. Yes. So this all are right. Okay. So now let us now study eclampsia, because eclampsia is very important. This is a question asked in INICT July 21, that the gravida, second gravida at 36 weeks, it comes with a BP, very high BP, 150 by 105, with a urine dipstick of 3 plus, and you inquire about the symptoms. So when a patient of severe preeclampsia comes to us, then we inquire the symptoms of impending eclampsia. What are those symptoms of impending eclampsia? Let's see. Those are headache, blurring of vision. Why there is headache and dizziness? It is due to cerebral hypoxia. Blurring of vision again due to this, or retinal hemorrhage. Okay, due to retinal hemorrhage. Nausea, vomiting, epigastric pain is due to the stretching of the glycine capsule of the liver, or liguria is due to the acute renal failure. Okay, so answer to this question, that you inquire about the symptoms of imminent eclampsia. Which is not a symptom of imminent eclampsia? Answer is persistent pedal edema. Okay, it is not a symptom of imminent eclampsia. Now see this question, which of the following is not a role of magnesium sulfate? Prevention of respiratory distress syndrome in the newborn. C. Magnesium form the, whatever the magnesium does in the mother, same the magnesium does in the child. Okay, whatever the magnesium does in the mother, same. So magnesium, more magnesium causes respiratory failure. So in the same way, in the newborn also it causes the respiratory suppression. So it does not prevent. So first answer is itself is wrong. Okay. Now prevention and treatment of seizures, yes, you all know this happens. Short term prolongation of pregnancy in mother at the risk of, yes, magnesium sulfate is also a good tocolysis. Neuroprotection in fetus in anticipated early preterm delivery, yes, yes, there is a neuroprotection in the fetus, okay, in the anticipated preterm delivery, because there is neuroprotection in the mother also, in the same way there is neuroprotection in the fetus also. Okay, so this is also correct. Now let's see eclampsia and magnesium sulfate, it has no effect. First of all, learn this concept that magnesium sulfate has no effect on blood pressure. You will able to correct many questions. Okay, so for the prophylaxis and for the treatment, magnesium sulfate is the drug of choice. If you don't want that your patient of severe preeclampsia get into convulsions, and if you don't want, and if you want that this eclampsia patient stops the convulsion, in both the cases magnesium sulfate is the drug of choice. Okay, it blocks the NMDA receptors and thus blocks the calcium channel. Okay, the drug of the regimen which is of choice is Pritchard regimen. Okay, here we give the loading dose of 14 gram. Out of this 14 gram, 4 gram we give IV, and 4 gram of this magnesium sulfate uh, is equal to 8 ml. Okay, and we dilute it with 12 ml NS, so we get the long 20 ml vial. Okay, we 4 gram of magnesium sulfate equals to 8 ml, and we further dilute it in the NS 12 ml. Okay, then the left 10 gram we give in the buttock, 5 gram in each buttock IM. Okay, now the maintenance dose, after giving this loading dose we give the maintenance dose. Maintenance dose 5 gram IM is given every 4 hourly. Okay, and then we have to monitor some parameters, and up till how much we continue this maintenance dose, we continue up till 24 hours after delivery or last season, whichever is later. Okay, so we will see whether the delivery is later or the last season is later. So after the 24 hour of these both things we will continue. Okay, now what are the parameters, because it causes depression of the brain, in because it blocks the calcium channels in the brain, so we have to control some we have to see some parameters so that magnesium toxicity does not happen. So the parameter are deep tendon reflexes, which we check by patellar reflexes. Respiratory rate, it should be more than 14, and pulse oximetry more than 96%, again to see whether there is any problem in respiration or not. And urine output, why we check urine output, because the main route of excretion of the magnesium is the kidney, only route of excretion. So urine output should be more than 30 ml per hour. Okay, now if the toxemia is happening, if any of these features are coming, then we have to titrate the dose. Okay, so pre-treatment, if one I'm not taking any magnesium, then the levels in my body will be less than 4. When we give magnesium to the level, the therapeutic levels are 4 to 8. At the levels 8 to 12, deep tendon reflexes they goes. So the first sign of impending toxicity is loss of the deep tendon reflexes. Respiratory depression occurs at 12 to 16, and respiratory arrest occurs more than 16. Okay, the antidote of all this is calcium gluconate, because mode of action it blocks the NMDA receptor and it was blocking the calcium channel. So antidote will be calcium gluconate. Let's see this question. 35 years old lady, 36 weeks pregnancy, came with a history of 5 convulsions. So this lady is having eclampsia. So the drug of choice will be magnesium sulfate. This is INS set May 22 question. Incorrect regarding magnesium sulfate. It has anticonvulsant effect on the cerebral cortex and simultaneously lowers BP. No, it does not lowers BP. Okay, rest all are correct. We have read it now only. IV loading dose of magnesium sulfate for prophylaxis in preeclampsia. So we give the Pritchard regime. Loading dose they have asked 8 ml magnesium sulfate plus 12 ml of 0.9% NS. So they have only asked the IV loading dose. Okay, so this was the question. Let's see. 24 years type 1 diabetes mellitus is in post-op ward following a cesarean done for the failed induction and severe preeclampsia. So this lady is having two problem, diabetes mellitus and severe preeclampsia. She complains of drowsiness and altered sensorium. She is on maintenance magnesium sulfate and insulin. So two treatments are going, magnesium sulfate and insulin are going. Okay, on examination her pulse rate is 70, BP is 140/98, respiratory rate is low, urine output is also low. Okay, lungs were normal, abdominal examination was normal, scar was normal. Okay, bilateral patellar reflexes are absent. Okay, urine dipstick test for protein and sugar is negative, capillary glucose is normal. So the answer to this is magnesium toxicity, because all the high magnesium level features they are coming. Okay. Okay, now let us see this is a neat PG 22 question. 34 weeks primary was having the jaundice. BP was 140/96. Bilirubin was 1.5. SGOT, SGPT in 150 and 200. Okay, and the LDH was 700 and platelet were also low. The RFT and coagulation profile were normal. So you know that this is HELP syndrome. What is HELP syndrome? Yes, now we will simultaneously we will study is severe preeclampsia and HELP syndrome. What is severe preeclampsia? If the BP is more than 160/100 and there is any end organ damage. How you will come to know if there is end organ damage? Already told to you that mainly two systems are affected due to the BP, kidney and liver. So if creatinine is more than 1.1 and liver enzymes are raised 2 times, it means it is a end organ damage of the kidney and liver. And if pulmonary edema and cerebral visual symptoms are there, then again it indicates a severe BP effects, and addition to that platelet count is less than 1 lakh. So in this condition it is a diagnosis of severe preeclampsia. Okay, what is HELP syndrome? HELP syndrome is hemolysis. Hemolysis indicator is LDH more than 600, or the bilirubin get raised more than 1.3, or there is low serum haptoglobin, or there is abnormal peripheral blood smear cells. Okay, or there is abnormal peripheral blood smear cells, then it is the indicator of hemolysis. Elevated liver enzymes should be more than 70 and platelet should be more than 1 lakh. Okay, that is HELP syndrome. So let us see this question asked was in FMG December 21. 24 years primary at 30 weeks has BP 160/120. BP is high, there is increased LDH, so this is indicator of hemolysis, and low platelet, so it is again a HELP syndrome. In fatty liver and hepatitis, the liver enzymes SGOT and SGPT, they are in thousands. Okay, okay, let us study now the drug used in hypertension. Okay, first of all you should know the what are the contraindicated drug. Is all the drugs which cause IUGR are contraindicated in pregnancy. They are ACE inhibitor, angiotensin receptor blocker, diuretics and diazoxide. Okay, the hypertension drugs that are safe is the labetalol, alpha methyl dopa, calcium channel blocker, nifedipine and hydralazine. So if they ask which is a drug of choice, it is of course labetalol. in every condition, whether it is chronic hypertension, whether it is gestational hypertension, whether it is preeclampsia toxemia, or whether it is emergency hypertension. In all this condition, the safe drug is the drug of choice is labetalol. This was a question of December 21, hypertensive drug of choice. So the answer to this question is methyl dopa, because propranolol is not given. Hydralazine is no doubt safe, but it is not the choice. Lisinopril is again contraindicated. Now here it is, any woman of 35 years, it comes from the preconceptional counseling. Which of the following antihypertensive drug needs to be stopped prior to conception? If which one of the following stop prior to conception? So it is ACE inhibitor. Okay, because what are the contraindicated drugs? ACE inhibitor, AR angiotensin receptor blocker, losartan, etc., and diuretics and diazoxide. So these are the so GFR in preeclampsia, GFR always decreases. Vasoconstriction lead to decrease in the hemoconcentration, due to which the GFR decreases. Now the prediction of preeclampsia, it is done by the uterine artery. It is done by the uterine artery. It is done by the uterine artery Doppler. Okay, 34 years woman is advised on ultrasound Doppler and double marker between the 11 to 14 weeks. Doppler of umbilical artery helps to predict. So the answer is early onset preeclampsia. Okay. Now let's see, prediction of preeclampsia is can be done by rollover test and uterine artery Doppler. If there is a diastolic notch after 24 weeks, then it indicates that preeclampsia will occur. Okay. Now let us see how we will manage the patient of the preeclampsia. So management of the preeclampsia, if the BP is controlled by antihypertensive, then we will terminate it at 37 weeks. We will not go more than 37 weeks. And if it is severe preeclampsia toxemia, then we will terminate it at 34 weeks. If any factor is uncontrolled, or the patient is help or impending eclampsia or eclampsia, then we have to terminate it immediately, irrespective of the period of gestation. We have to save the mother. Okay, and always we prefer induction of labor. We will terminate the we will do cesarean in fetal distress or poor progress or uncontrolled BP or uncontrolled fit. So this is a question which has come in NEET PG 2020. 35 years primary at 38 weeks. Now this is at 38 weeks, and this is a twin pregnancy with first twin breach. So you know, in first twin breach we do cesarean. On examination, BP is 140 by 90 and proteinuria 1 plus. It means this is a case of preeclampsia toxemia. Okay, and because in preeclampsia toxemia we don't go beyond 37 weeks. So here it is, the patient is already 30. We have to immediately do. In the first twin breach we do cesarean. So answer here is immediate LSCS. Okay, so that was the topic of preeclampsia. I hope I was able to clear your concept. Thank you.